So the correct answer is B, MRI brain, and that is because if you can see for the other options, why would you go for a CT pulmonary angiogram? Well, if you're trying to rule out a pulmonary embolism, and in this case, you can very clearly see the patient is heart rate of 50. He's not tachycardic. You also see other things. The D dimer is normal, which pretty much rules out a pulmonary embolism. The bicarbonate is normal. So obviously not likely. Then you got the blood and sputum cultures, and that would be in case you're thinking the patient is septic. And in that case, you might have the TLC that would be raised, the bicarbonate level would be low, the D dimer would certainly be increased in cases of sepsis, which is not the case here. The echocardiogram. Why wouldn't that be a choice? Because if you're thinking of any cardiac cause like MI, or you're thinking of any other thing like pulmonary embolism, there might be other things that you would see. All of those are negative. The troponin I is negative. So then that leaves MRI brain. And if you see the patient's vitals, his blood pressure is increased and his heart rate is bradycardia, right? His blood pressure is increased and his heart rate is low. So this is meeting the Beck's triad. What is the Beck's triad? If you know, that is hypertension with bradycardia and decreased response that occurs in a patient who has a stroke. And so in case of increased ICP or intracranial pressure as a result of pressure effects in the brain, you see that these vitals come up. So likely an MRI brain would be needed to find out if the bleed or stroke that the patient has, now in this case it's a stroke, middle cerebral artery infarction, has increased in size and the pressure on the brain is increased or not. And as we have previously shown you in a in this diagram, if there was a middle cerebral artery infarction here, it can very well cause the pressure to increase and the brain to herniate down below here. Eventually, the pressure can transmit here and the brain can completely herniate down from below the foramen magnum. And that would cause ataxic breathing and bilateral weakness because of the herniation. Now, you've already evaluated the patient of coma, and in which you have started, as we have shown you through the flow chart, with the general physical examination, the neuromotor examination, eye examination, respiratory pattern that you have assessed. All these things you have done to determine the exact location or cause of the comatose state. Next is you have to confirm these findings, right? So of course, if you're thinking of the brain, then you have to get either a CT scan in plain brain or a preferably MRI brain. Now, MRI brain might obviously not be possible in every situation, although it is the best thing to do for structural causes or abnormalities to find out. But in case a patient is in a very bad shape, and they cannot be moved for an MRI brain or not be stationary for an MRI. A CT scan is a very effective, brief study that you can carry out, and it can also show gross abnormalities. And if you're considering infection, then you have to do a lumbar puncture, get the CSF, and check for infection and infective markers. If you're thinking of obviously seizures, you do an EEG to rule out seizures, either clinical, subclinical, so those things as well. And otherwise, if you're thinking to rule out, which you should in all the cases, metabolic or diffuse causes, then you have a very good mnemonic here that I've shown. So it goes by TOMES or TOMES, in which T stands for toxins or drugs, so US serum or urine tox screen. Organ failure, you have to look for uremic encephalopathy, so you check the urea levels. Hepatic encephalopathy, you can check the ammonia levels. Metabolic causes, you can check for hypercapnia or hyponatremia or hypoxia by doing an ABGs. You can check the electrolytes and check the glucose levels. So all those things again. Endocrinopathies, in which disruptions with the hormones can cause the patient to become comatose. So in cases of adrenal or thyroid dysfunction, you check for those respective hormones, of course. And then if you move on, finally we have seizures. And so for seizures, you do an EEG, and you have to then hence rule out a convulsive state of the patient or a post-convulsive or post-seizure confusional state, which can also present in a comatose pattern. Now, you need to know what is a vegetative state. As explained here, you have a persistent comatose state, which is called a vegetative state. Now, how do you define it? It either may be persistent, okay, that is which is lasting for about 1 month. The patient is in a constant comatose state and not waking up, or it will be permanent. The permanent one is defined as a comatose state that lasts for at least 12 months after a traumatic brain injury, or at least 3 months after a non-traumatic one. So for obviously traumatic ones, you will even know it could be because of an RTA, or a road traffic accident, or any other injury, for example a gunshot. And for non-traumatic ones, you can have any cause. Basically, it could be a tumor, it could be a bleed, it could be a stroke. So persistent vegetative state patients, you have to understand, are in a bad shape. Obviously, they rarely improve, but there are exceptions, and we have seen it in case reports here and there, but normally it does not happen. There are very limited options for such patients who are in a vegetative state. Some things that are ongoing, and some physicians, what they will do is sometimes transcranial magnetic stimulation or electric stimulation to try to make the brain come alive somehow and to make the patient wake up. They are used in some places, but with limited efficacy, have not proven useful. And some pharmacological agents are used in some cases, like zolpidem. But again, there is little evidence backing their usefulness or efficacy. So there's just, you need to know that the options are there which are being used. So it's a area of currently research and ongoing, unknown uncertainties. So that's all for this topic. We'll talk about more in the upcoming videos. Until then, stay tuned, and let me know in the comments what you like, what you don't like. And obviously, email if you have any questions or you would like to know anything. Thank you so much.